Hi everyone, this is John Goldblum. What I'm going to do is spend about the next hour or so just showing you some cases of some well-differentiated lipomatous tumors. Many of these cases come from our consultation files and really represent the most common types of consults that we see. And in fact, well-differentiated fatty tumors are one of the most common consults that we see overall, and these are pretty representative of these. Some of these have specific clinical histories, others do not. I'm going to limit showing any immunohistochemical stains, but I can sort of tell you when there are relevant immunohistochemical stains and or molecular studies that are pertinent to a given case. This first case is a pretty typical case. It arose on the upper back region of a 60-year-old male, and what I'm showing you here is a low-power picture showing you that you can't see that much from low power, but it's a fairly well circumscribed lesion with some fat and some cells. That's really about all you can tell at this magnification. But just to make the point that this lesion looks like it was just kind of shelled out. Now, it was superficially located, which you wouldn't necessarily know by looking at the slides, but it was superficially located and it was removed by a general surgeon. And very often, lesions such as this are removed by general surgeons because they're superficial, and often these get shelled out. So at higher magnification, you can see that there is an admixture of fat and a pretty cellular proliferation of cells, which even at low power, you can see that there's some cytologic atypia here, which is a little bit concerning. Spend a little bit more time going to higher magnification. This is pretty cellular. Most of these cells in here are spindled cells, but you can certainly see some enlarged hyperchromatic nuclei as you move around. I'll move the slide around a little bit. There's a little bit of inflammation in this case, which is not particularly typical of this lesion. And here again, you can see some enlarged hyperchromatic nuclei, some of which almost look binucleated or multinucleated. Go down to higher magnification and show you some really bizarre looking cells here. Sorry, I'm just trying to get in focus here, which can be difficult. Some really atypical looking cells, as you can see here, hyperchromatic. This area has a little bit of, the reason it looks so light is because there's quite a bit of myxoid stroma in here, which is often seen in this lesion. And then, let's see if I can't move it around a little bit more. Find some, again, this is an area of really high cellularity with some multinucleated cells. Sorry about that. Now, what I'm trying to show you here is actually a very difficult example of a pleomorphic lipoma. That might even be a mitotic figure. You can see some mitotic figures in pleomorphic lipomas. One thing that's kind of missing from this particular pleomorphic lipoma is the very ropey eosinophilic collagen that is pretty characteristic of pleomorphic lipoma. So the bottom line is you've got an atypical neoplasm here with some fat and some hyperchromatic nuclei, including multinucleated cells. Now I'll show you an immunostain. The only semi-relevant immunostain that was done in this case was a CD34. This is the CD34 immunostain, which was sent along with this case. This was a consultation, showing you that the lesion is very strongly CD34 positive. Virtually every cell, including the multinucleated giant cells. So let's go to lower power just to show you how diffuse the CD34 immunoreactivity is. Pretty much every cell is positive for CD34. So this is a pleomorphic lipoma, as I'm sure you've probably already figured out. In terms of its clinical setting, upper back is certainly a good spot. Virtually, 80%, 85% of pleomorphic lipomas occur in the posterior neck, upper back, or shoulder region, usually in middle-aged males, and I believe this individual was a 60-year-old male, so that's a pretty typical clinical-pathologic setting. But from a histologic standpoint, this particular case is a little more difficult because it's so cellular, there's really not that much fat, and it's kind of missing the eosinophilic ropey collagen that's characteristic of this lesion. Regardless, I don't necessarily think even a CD34 stain is absolutely necessary to do, although it is certainly confirmatory. The problem is, as I mentioned in my lecture on this topic, CD34 is not a specific marker by any means and can be found in virtually any other neoplasm if you stain enough sections of it, including well-differentiated liposarcoma, which is the only other reasonable lesion in the differential diagnosis.